All right, good morning. It's 7 minutes past 8. For those of us who are aware that there's a problem that the whole country has been put on alert for, I think it's important for us as a department to be aware of the surveillance that is in place around monkeypox virus. So essentially, I'm going to cover the basics of clinical presentation, epidemiology, what is available in terms of management of these particular conditions. And of course, we'll look at some of the preventive strategies that needs to be put in place. Those are the things I'm going to cover. But just as an overview, monkeypox virus, in the literature, you see terminologies like Mpox, which is a WHO attempt to destigmatize this particular condition. So if you come across Mpox virus or monkeypox virus, they're essentially referring to the same virus. We know we've had experiences of what we call zoonotic diseases, in which conditions that typically infect animals, then gets transmitted to humans. For example, rabies. We are familiar with that, and we make every attempt to prevent rabies after any form of animal bite or scratch or nibbling on some mucosal or open skin. Again, monkeypox virus is one of very many zoonotic diseases that we should be aware of. And because of the ramification of this particular virus, now WHO has declared this virus as a global public health emergency. And therefore, if we are in our family medicine department or you work in emergency unit, you need to be you need to have enough information to be able to suspect potential cases of monkeypox virus. In terms of microbiology, it's important that we understand it's a double-stranded DNA virus from the family of Pox viridae. And over 80 different species of Pox viruses have been reported over the years, which specifically infects mammals, birds, reptiles, and insects. But with regards to transmission to humans, two known pox viruses, two different viruses of the same family of Pox viridae have been documented. Smallpox killed a lot of people in the early 19th century. And that led to development of pox vaccine that were given as mass vaccination. And that led to eradication of this particular smallpox. However, in fact, of 1980, mass vaccination against smallpox virus was stopped because the virus had been successfully eradicated. The only people that were then reserved to be given a smallpox vaccine were those people who work with highly infectious materials in the laboratory. So no other people were allowed, were given a smallpox vaccine after 1980. But molluscum contagiosum is still very common in our practice population. You see nodules on the faces of children, highly infectious through contact, and as you will see, when I show you the pictures of what monkeypox virus looks like, it's almost clinically indistinguishable, especially at some faces of this particular virus. So please be aware that there are two different clades of monkeypox virus that have been documented. The popular one, or what we call the Central African clade, or clade 1, has got 5 different lineages or subtypes, while the West African clade, or clade 2, has got 2 different subtypes. That's subclade 2BA and 2B. And these clades aggregately, generally believed to have been endemic in Central Africa. As you can see, the Congo, Democratic Republic of Congo, Congo, Brazil, with overlap between the Central African clade and the West African clade in Cameroon. But again, when you look at the West African clade, it borders from Sierra Leone down to Liberia, Ivory Coast, Ghana, Nigeria, and of course, an overlap with the West, Central African clade in Cameroon. The Central African clade is a little more virulent, more infectious, and more deaths in that particular, with this particular clade. But what we are beginning to see is that there is now evolution. In fact, I was listening to the CDC presentation on monkeypox virus. They have actually seen evolution of the 2B clade, especially in the United States. Predominantly among patient individuals who are immunosuppressed, men having sex with men, especially those with very low CD4 counts. They tend to have a more rapid spread. Now, just to take us back to historical concepts around monkeypox virus, the very first cases of monkeypox virus was discovered in 1958, largely due to outbreak within laboratory, and the first diagnoses were made in monkeys that were kept for research purposes in Denmark. The exact animal reservoir is still unknown, but it's believed that rodents, squirrels on the trees, as well as monkeys, may actually have been the main source of this virus. And through hunting for these animals, especially in the Central African Republic, West African region, we are hunting for animals for feeding, it's a typical practice. It's believed that, transmission to humans have taken place through that process. But again, before 2022, this particular virus actually limited to the endemic zones. But now we are beginning since November 2022, there have been, rapid spread across Europe and America. And that's what led to the global declaration by WHO as a public health emergency. And this is just to show you the timelines of what has been happening, okay? Now, a lot of human-to-human transmission have taken place in Congo, Democratic Republic of Congo. And of course, in Ghana, some cases were, outbreaks were reported to have through migration of animals. I'm sure for those who monitor the news, there were 2 pandas that were migrating, that were loaned from China to USA, and it was, in the news. So those migration of animals, often than not, may lead to transmission of, viruses or other infections that are peculiar to those animals as well. As of January 2022, since January 2022, over 100 countries have reported outbreak to WHO. And of course, at the end of May this year, close to 100,000 laboratory confirmed cases have been reported to WHO. And of course, in addition to that, there are about 535 probable cases waiting for laboratory confirmation. But the number of deaths have equally, have been outstanding. 203 cases have died, okay? The concurrent outbreaks in both endemic and non-endemic areas, is the reason for the declaration by WHO. I already touched on the need. When people are infected, travel from one country to another, they go with the virus and infect other people. Also, animals traveling with their pets who may already have been infected equally will lead to further spread in the new destination. And those are the reasons for, transmission. Now, in terms of WHO recommendation for assessing risk, if you are from a country where there's not been any outbreak so far, in Eastern Cape, we will say in Eastern Cape, there's not been any single confirmed cases, even though there was a suspicion of a case, I think sometimes last week, but it's not been confirmed. So if you are from any area where there's not been any confirmed case, then we'll consider you as a low-risk individual. But the moment some cases have been reported in your area, that already puts you at a moderate risk. And of course, anybody who is immunosuppression will be classified as moderate risk. But if you are coming from countries that the virus is endemic, for example, DR Congo, you are already classified as a risk individual because there's potential that you may already have the virus in your body. According to the documented data based on confirmation in South Africa, as of end of April, this is the global picture. You will see that there is huge surveillance for this monkeypox virus in America. As you will see, the numbers are quite far more in the, in region of Americas, which will include both North and South America. I think we have got the global map. If you look at those deep blue areas, those are areas that have documented more than 10,000 cases, based on laboratory confirmation. And if you're familiar with the map, this is Alaska, which is part of the United States. Okay, and that's United States, that is Brazil. And of course, those who have got more than 8,000 cases, then you see Canada there, okay, as well as, Argentina, and of course, China there, okay? And that's the Congo Democratic Republic. So you will need to be familiar with some of this, what's going on around us. So far, this is the data from South Africa. 2 cases have died so far from, 2 confirmed cases have died of monkeypox virus. But when you look at the distribution, you can see they are likely affecting young people. Okay. What is not immediately clear here is the HIV status of the patient. It's understandable. People, they want to put a label on that. But we know that those who are immunosuppressed are more likely to have more severe cases. Okay. In terms of the transmission route, now, any form of transmission is through bodily effluents, either through the fluids or the blood or eating meats that are undercooked, okay? And you can see animal to humans transmission through bites or scratches on the body of humans. And of course, from, within animal transmission is equally one of the issues that have been reported. But human-to-human transmission equally becomes very critical. The moment you are in close proximity, less than 1 meter space within infected individual, through respiratory droplets, through droplets while you are talking or sneezing, or coughing, all of that increases risk of transmission to the next person. Okay, and as you will see, there is a whole lot of other scenarios that have been included within the setting, and direct physical contact or skin to skin with infected lesions on the skin will lead to increased risk of transmission. And that's why issue around sexual transmission becomes an issue. Not because the effluent is transmitted through semen or vaginal fluid, but largely because of the skin to skin contact. If you hug somebody or you touch somebody who has got lesions that have not healed completely, you are more at risk of contracting the virus. As you can see, infectiousness starts from the point when the same person becomes symptomatic until the lesions on the skin, those nodules and the pustules have healed completely. So, and that is really a concern because especially for our nurses who are involved in triaging patients, especially in emergency unit and the outpatients, they will pull, they put cuffs on inflatable cuff on the arm of patients. They use the same cuff and put it on the next person. And how many of most times when we see patients, we do really disinfect our hands in between patients. If we do begin to see this type of cases, then these are some of the infection control measures that compulsorily we have to implement. And I think it's best if we start practicing that even now. so that we improves our chances of minimizing contact. All right. Now let's look at indirect contact. We think when we talk about highly infectious conditions, we are most worried about doctors because we are the ones that consult these patients. What about those cleaners? The cleaners who are going to remove the beddings from the bed linen. They are the ones that will clean chaps in the consulting rooms. Those are equally at risk, because the moment you put your hand on infected materials, that increases your risk of acquiring the virus. Contaminated chaps, medical needles, those who are involved in performing tattoos on patients, those chaps they use for doing tattoos can equally be medium for transmission. What about settings, homes, community homes settings? People within households are all contacts of an infected individual. And if we do pick up or suspect any case, all of those households now members needs to become contacts that needs to be surveilled for potential cases in this patient. Surprisingly and scarily is that mother-to-child transmission have equally been reported via the placenta and during pregnancy, even during and after delivery for newborns. Okay, and I think that's the aspect that guys in maternity will be most worried about. I think I already highlighted this in terms of human to animal transmission, but critically, eating undercooked is a challenge for transmission. Okay, and of course, people in the rural areas where any animal is for consumption. If infected animal is shared and cooked and and consumed, then of course, except if it's adequately cooked, in which the heat will destroy the virus. Otherwise, the potential for transmission becomes a concern. Okay. And I think I've highlighted those. Now, how do these patients present? It's important that the incubation period, though very variable, but it can last up to 23 weeks. Okay. And during the prodromal phase, take note of these symptoms, because it's not different from any of the flu viruses that we all have flu from time to time. And the presentation is typically not different, as you can see. But the moment you have rash on the skin of that person, that cannot be explained by any other common conditions that we see often in our practice, we must have a high index of suspicion. In fact, as this surveillance is ongoing now in Buffalo City, and there will be a lot of training. I've been tapped up to be part of the trainer from next week. So we'll be doing a lot of training in the district, and they're bringing doctors and nurses to somewhere in town where training should be conducted. So the idea is that everybody needs to be sensitized. And the moment you see unexplained acute skin rashes, you need to immediately flag it off so that people, appropriate processes can be implemented. Okay. This is just a natural progression, but I think this explains it better. Okay. So the prodromal period, this is one of the, I'm not so sure how well we are going to do if we begin to see these cases, because the moment the person starts having fever, sore throat, body pains, that person is already shedding the virus. How is that different from anybody having flu? So by the time the patient is now developing rashes, he has already spread the virus to several people. And the implication thereof is that we must then go back and begin to provide a list of all the contact of these individuals. For example, a lot of time we have flu and we come to work. All right. And now, how many patients have you seen over those periods before the first rash develops? And not to talk of household members, how many contacts that you may have, that potentially may have been at risk of getting the virus. So we hope that we are not going to have to deal with this particular condition. Of course, mortality in comparison to COVID is far less. But of course, we never know who may have the underlying medical condition that may cause immunosuppression and then increase the risk for fatality in this patient. So please just be aware, you know, in terms of the progression. And if you want to look at the key problems, the presentation is equally variable in patients. Some people, a lot of the patients will have rashes, okay? So maybe that will help us to think of monkeypox virus in a patient, but all the other symptoms are not specific, okay? So we need an index of suspicion. There is national alert and there is provincial alert. Now BCM is on alert with regards to this particular condition, and they have been trusting us as doctors in the forefront to be able to pick up these patients and immediately notify appropriately, so that even if you suspect, you must notify of your suspicion, so that patients can, and every system in the body can be affected, as you can see. A lot of individuals who are immunocompetent will have very mild disease, and the symptoms are going to resolve spontaneously within 2 to 4 weeks. But the few patients will have severe conditions, which may include pneumonia, encephalitis, and anybody with encephalitis will require hospitalization. And the risk of death will be higher in this category of patients. Pregnant women maybe are more likely to have a more severe case. And of course, children, even though the risk is less in children, but for children who gets infected due to immunocompetency or immature immune system, they are more likely to progress to condition. This is a very, very important part. Again, a lot of the patients are not going to present during in the stage 1. All right. Except maybe young ladies, when you see certain skin changes, especially on the face, because the lesions will start on the face and then spread to the extremities. Now, but a lot of the people, especially men, even when they see papules and vesicles developing, there is a very little chance that they are going to come and consult. Okay. And even when they see, when the vesicles now start having pus, they are very, okay. They are it's very likely that people are going to present very late. And of course, people are more likely going to attempt to treat the condition by themselves, such that by the time they come to us, they will have spread the virus to far more people, too many people to be surveilled and curtailed. So essentially, this is just the progression of the rashes on the skin of patients. This is probably that is let me see. Yeah, macros and papules, sorry. So the raised lesion is papules. You begin to see vesicles, pustules with pus inside, which can burst and cause excavation there, and that's what they call scab. Until this lesion heals completely, the person can still spread the virus through those lesions. That is the thing. And if we need to obtain specimen, we can either aspirate the content of the pustules or the vesicle, or we can simply just swab directly on the lesion for PCR, so for diagnostic purposes. Now we'll spend some time. Now, every lesion, every part of the body, remember, it's going to start on the face and spread to the extremities in individuals. These are the ways you are going to see it in different parts of the body. Patient may present and his face, Okay. And you can see there different form of lesions. The only challenge we have here is that even when patients present with these lesions, there are a whole number of other differential diagnoses that we immediately jump into our mind. And except we think about it, these are not so pleasant. These, again, every skin to skin contact will lead to the spread of this lesion. These are some of the pictures in case you see patients. Maybe men will present when they have this type of problem. So you need to know what to look for. Again, look at what you are looking at on the face. Where are the 6 years? Yes, 6 years. Umbilicated nodules or lesions. Besides monkey pox, what is the closest differential you have for that? What are the other conditions that will give? Very common in children. Molluscum contagiosum. Any other condition that may give umbilicated lesion? Where are the intents? Umbilicated lesions. It can actually be widespread all over the body. Very painful, itchy. May cause encephalitis. Chickenpox. What else can cause that? Common things occur commonly. If it's localized around the mouth, and somebody who is sneezing and coughing, what would you talk about? What would you consider? Herpes. So there is, the differentials are wide. So it's just we need, when you see those lesions and you cannot explain that, we may need to put a label where it's suspected. And then, of course, we'll then have to proceed to obtain specimen, for PCR to confirm the patient. Wherever contacts can take place, either anal sex, genital sex, vaginal sex, those lesions will be present in those areas where there is skin-to-skin contact. Okay? In the United States, most of the cases were reported among men having sex with men. Okay? So we don't know the sexual orientation of those patients in South Africa, but definitely the key issue is the contact. Skin-to-skin contact will lead to lesions. Again, if you see this in the genital area, what other differential would you consider apart from herpes? It's very unlikely to be chickenpox. That's localized to the genital area. What other condition that is very common? Interns, where are our interns? HPV, but that is the virus. What is the lesion that is showing on the skin? What? So these are the differentials that you need to be able to exclude in your mind as these patients come through your door. Okay? They recommend we are not going to swab every patient, but the moment we confirm the case in any particular region, every patient coming from that region becomes a potential case. Are we clear on that? Okay. Just to give you an idea of what it is that we are looking at. And very unlikely patients, especially at this level, very unlikely will patients have fever, sore throat, body pains, back pain, and run to CMH. They may probably run to the CHCs and all of that. But the moment the first case is diagnosed, there will be anxiety in the community. And there are going to be more and more cases that will be coming through our doors. Just for us to see and reassure them that it's very unlikely or it's likely, we are going to investigate this further. Okay. In terms of the WHO recommendations for case definitions, suspected case essentially is about you identifying unexplained acute rash in patients and I've shown you the evolution of the rashes. So a patient can come at different phase, whether it is from a macular lesion in which the skin is flat, or the skin is slightly raised, less than 2 centimeters, pulpos, or vesicles in which there's clear fluid inside, or pustules with pus inside, and the pus can burst open and form a scar. So take note of the evolution of the rashes, and typically we start on the face. As long as the patient comes to you, his calf's got concern, maybe somebody said on the news that there is monkeypox virus, he's running to you, they need you to reassure them. Is it very likely? Is it a suspected case? You need to see. In the same patient, there must be, in addition to the rash, does the patient have at least one of all of these other symptoms that we have been listed? Okay, so you need to obtain this history in this patient. But more importantly, can the rash that you have seen, can it not be explained by any other common condition? So which means you have to think broadly. That's why I was trying to stimulate everybody to look at those pictures and think of what else can it be? What are very common problems in our population that you need to exclude? Otherwise, we are going to be swabbing 10, 20 patients every day, you know? And the process of swabbing itself is quite tedious because you are dealing with highly contagious condition, you know, and that requires a specific process to be followed. Probable case will be any case, any suspected case that has got a link to somebody that's either been confirmed or somebody that is a suspected case. For example, you saw a patient now, you label as suspected. A week later, somebody is coming from the same household. That person is no longer a suspected case. It's a probable case. Okay? The only difference is that you have now, the moment you obtain specimen and the result comes out as monkeypox virus, that definition changes to confirmed case. Are we clear on the definitions? It's just basic epidemiological term. Suspected, this person is coming to you, you've seen the rash, he's got those symptoms, what looks like flu-like symptoms. You cannot explain the rash based on the common conditions we see, but you have not yet obtained any specimen. That would be a suspected case. We are meant to isolate that person until the result is negative. Now, should the patient be admitted or the patient be managed as outpatient? It's strictly a question of the severity of the patient. The more the rashes, the more the severity. And the cutoff of 100 lesions on the skin is associated with severity. But however, patient may have myocarditis, patient may have pneumonia, viral pneumonia on presentation, they may have encephalitis, patient is confused, you know, on arrival. That patient will require hospitalization. Are we clear on that? Now, I know as a way of curtailing the spread, we will need to watch closely with the public health team to see. Maybe if we do get to the stage when we see 1 or 2 cases coming through, maybe they will make a case for isolation in the hospital because we know the social environment where people live may not be conducive to isolate people who live, you know, somebody who live, maybe 4 or 5 people living in one single room shack. How do you isolate that person there? So we may have to, once we get to that stage, there will be more information that will come through from the department. Every suspected case needs to be reported. And this is part of the public health component of this particular condition. It's a notifiable condition, and their goal is to make sure that it doesn't get a base or create an outbreak. As a matter of fact, any single confirmed case is considered as an outbreak. That's how serious the department is with regards to this particular condition. So we are going to be getting some of these monitoring tools from NHLS. These are NICD documentation. So in terms of how we are going to monitor any case that come through, so we you know, so far there is no confirmed case in Eastern Cape, But all of these documents are ready to be utilized in the country, which will be shared at some point. Again, every potential case, every suspected case, we will need to document all their contacts. Now, there are 3 different modalities of contact. Again, we still don't know which one will be employed, especially in our province and, you know, in the province or at BCM, there is a passive monitoring or passive surveillance in which the patients will be issued a thermometer to check their temperature in the morning and evening. And then if the patient starts having fever, that, any of the contacts will have to phone in to a designated officer or in the district. There will be people specifically assigned to monitor contacts of suspected case or probable or confirmed cases. Then also there is provision in which there is a designated officer who will be phoning in to check with the contacts every single day to check how they are doing, their symptoms evolving, and if symptoms develop, they are immediately brought to the hospital. And of course, which is an active surveillance, and of course, patient themselves, the officer, they're actually doing face-to-face follow-up with patient. That will require a lot of resources. I don't know if it becomes an outbreak, then it may be difficult, because we remember we started that process during COVID, but immediately the number overwhelmed the people who are doing the surveillance. We have to stop that process. So this is another form for reporting of symptoms, which will be given to every contact. Again, all of these will be made available if we start seeing patients. Process of collection of sample, which is expected that if you suspect a case, first you have to notify your local laboratory so that they can provide you with the materials for specimen collection. Okay. The specimen itself is highly contagious, not just only to you obtaining the specimen, even those who are going to work with the sample in the lab equally have to be protected in terms of, So these are the materials we are going to use for collection. We must not use the gel. In our consulting room, we have this gel containing transport medium, which we use for collecting other bacterial samples. That cannot, it's impaired. Gel impairs PCR, they won't be able to process that. So that's why it's important to talk to the laboratory. And the specimens, the best specimens are those coming from those lesions, if we can aspirate the vesicles or the pustules, and then aliquot it into the transport medium. That gives the best picture, because they need to isolate the virus for diagnosis. Either they do full sequencing, but PCR is available. So just for us to be aware of those. Transporting and packaging. 3, again, this is one of the reasons why the local lab must be involved, because they want triple protection around the specimen itself, just to make sure there are no leakages, no contamination of the content. Sometimes people, you don't seal properly and the thing, seeps out and then contaminate the specimen bag, like we normally would do when we obtain specimen, either for, pleural fluid or acetic fluid, and some of them will seep into the wraps. We want to avoid that. That's why it needs to be triple, covered when transporting the patient. Ideally, should be transported on ice. Remember, they need to isolate the virus. Okay, so very, very important. Every suspected case, we need to notify the lab, and then they need to be involved in the process. And that is the form that's specific for monkeypox surveillance, which should be made available from our NHLS. I've tried to contact Mr. Babonke, but I've not got any feedback yet in terms of our own local readiness. So far, we don't have any case, but we need to be ready. We never know when somebody will come from Oteng or KwaZulu-Natal. I'm sure some of us travel to Durban for weekend and come back on Monday. You never know when we are going to see a single case. Diagnosis is likely PCR based, which will be done in the lab. How are we going to manage these patients? Most of the cases will be self-limiting. It may take 2 to 4 weeks, but it will be solved. In few patients who are immunosuppressed, they will have severe cases. Children, very pregnant women, those who require more attention. Then what do we do as supportive management? Antipyretics. So definitely patient will benefit from paracetamol, plus or minus NSAIDs, antihistamines, chlorpheniramine, cetirizine, loratadine, whichever one that is available to you, just to reduce the scratching of those lesions. Okay. Antiseptic bath, and also for oral lesions. We may need to give Prelocaine if there are lesions in the mouth or the mucosa, so that the patient wouldn't be able to eat. Otherwise, it becomes extremely very painful, Warm baths, Prelocaine gel. We are familiar with that, or spray. Prelocaine spray or ametocaine gel and spray. These are options to make sure that those lesions, you can at least numb those lesions so that the patient can be comfortable. And of course, bacterial antibiotics to prevent superimposed bacterial infections. And such individuals need good hydration, nutrition as well as nutrition. Now, this is an antiviral drug, which is a Schedule 21 drug, the same category with ivermectin. Well, we all know the story of ivermectin that will require a separate process. We have to it needs to be ordered on named patient basis with motivation from the treating clinician before it can be approved. Okay, so it's not a particularly this drug was used for smallpox back in the day. So now they are bringing it back, and it's been shown some efficacy, but not every. It's only for patients that with severe condition that would need to be treated with that. Now, where are we with regards to immunoglobulin? There is a lack of efficacy in terms of providing passive immunity, following confirmation of diagnosis in patient. But what is known is that the max vaccination used for smallpox, have shown some form of efficacy. That's like 2,000. But this is associated with a lot of complications. So now they are moving to Jynneos is what is FDA approved in the United States, which is available for people who are immunosuppressed. And of course, people work in laboratories who are working with these viruses, you only have to get it. It can be given as pre-exposure prophylaxis as well as post-exposure prophylaxis. So far in South Africa, they are not available, but we are hoping that it's going to be available. South Africa got some, after the first diagnosis case in South Africa received tecovirimat, and our pharmacists here, they are equally aware of the process. So if we get to that stage, they will have to source it. Mamelodi, there's one hospital in Mamelodi that have got a few supply left, according to the pharmacists. So the vaccine, Jynneos, is available as 2 subcutaneous injections, 28 days apart, but not yet available in South Africa. But if this trend continues, it's going to come to South Africa. So essentially, if you see any lesions that are suspicious, the first response is to isolate the patient. Now, how are we going to achieve effective isolation for patients? That we need to take into cognizance the social context of the patient. Okay. We are not going to be able to admit every patient, but I'm sure if we begin to see cases, definitely the department will have to make provision for maybe temporary isolation in the hospital at some point. That we just need to monitor this best. But we must immediately notify the our local NHLS, so that we can then follow the process of obtaining specimen, transporting the specimen in appropriate manner to ensure that the virus is preserved within the swab, and therefore the rest of the process can follow. We'll provide supportive care for the patients. Only very few patients will require admission, And of course, if those patients that require hospitalization, then the treating physician will have to then provide, make application for Schedule 21 drug, which can then be supplied from the source. That is the process. What about care workers? So again, these recommendations may change in the next few, I will say the next few days or next few weeks, depending on what is happening on the ground. So far, they are saying patients should be isolated for 21 days. Contacts should be isolated for 21 days. Patients should be isolated for 21 days. But we are saying occupational exposure who is not symptomatic should take necessary precautions to prevent spread to patients, but you are not going to be isolated. So that recommendation may change in the next few weeks. Okay. And during the period, we want to make sure that such a clinician or healthcare worker should not work with immunosuppressed individuals. In case that person now starts shedding the virus, you don't want to shed it to somebody with immunosuppressed. That is a recommendation from the Department of Health as of now, but that can change in the near future. We already know we've got a lot of experience from the COVID period in terms of PPE. So when we approach our patients, we must make sure we have our gloves, we need to have our goggles, and then of course face masks to prevent respiratory droplets from the patient. Again, it's our responsibility to protect ourselves. The moment you see something suspicious, you must, without stigmatizing the patient, you take necessary precautions to make sure you don't go home with the virus and spread it to your family. So that's the lessons that we are taking from there. The infection control team, we've got a new infection control nurse and they have been activated. They are starting training for all the nurses in the hospital because if we start seeing these cases, everybody's at risk, from our cleaners to our porters to the kitchen people who are serving medication, who are serving food in the ward. Everybody is at risk because indirect contact through infected surfaces, infected material will serve as mode for transmission. And we need to go back to disinfecting our hands after we see every patient, which I think we seem to have forgotten in the last 2 years now. Okay. Again, those nurses who are changing beds, linens in the ward, equally need to do the best to make sure that they don't go with the virus. The same thing with the laundry team. If a patient dies, there's a process in which such patients should equally be handled, which are well detailed in the infection control component of this particular guideline. Thanks very much, everybody. I'm sure there will be 1 or 2 questions.